Good morning, everyone. My name is Thareenee Wiswannadan, and I'm a Senior Public Health Executive at the National Cancer Society of Malaysia. It is my great privilege to serve as your moderator for the 37th SK Dharmalingam Lecture Series. Before we begin, I would like to share a brief introduction about Dr. SK Dharmalingam, our Malaysia's first oncologist. This lecture series, held monthly on Dr. T, focuses on various cancer-related topics aligning with the cancers of the month. As our tradition, we hold the sessions at the end of each month. Today's session will address a crucial topic on smoking and vaping cessation in conjunction with the World No Tobacco Month. Thank you all for joining us, and let's have an engaging and informative discussion. About our speaker today, our speaker will be Dr. Takdir Singh Riar. He started his medical journey at the Royal College of Surgeons in Ireland in 2001 and completed it in 2007 at Penang Medical College with graduating in MBB CHBAO. He successfully graduated with a graduate certificate in family medicine under the Academy of Family Physician in Malaysia in 2017. Dr. Takdir is now continuing his journey to obtain FRCGP under the AFPM and Royal Australian College of General Practitioners. Currently, Dr. Takdir is practicing in the primary care department at the Tanglin Health Clinic, Klinik Kesihatan Tanglin, and is in charge of the Klinik Berhenti Morocco Smoking Cessation Clinic since 2014. This smoking cessation clinic has been the top smoking cessation clinic in Malaysia with the assistance of his team, which comprises a medical officer and a medical assistant. The smoking cessation clinic has received many accreditations and awards and has become one of the training centers for smoking cessation services in Malaysia. Dr. Takdir's team has successfully innovated a nicotine addiction management toolkit, which is the Quit ASAP, as a innovation project which has won national awards under the Ministry of Health Malaysia and is currently being replicated and used throughout Malaysia. So Dr. Takdir Singh today will be presenting on the management of nicotine use first, and then moving on into an understanding of the assessment. I do hope that everyone enjoyed this discussion. Over to you, Dr. Takdir.
Hi, very good morning. Thanks, Thareenee, for the introduction, and thanks to Doc Equity for having me today to give this talk on this cancer causing agent, which is coincides with the month of World Tobacco Day, which is on the 31st of May. So without further ado, I would like to start off my talk. The first thing that I would like to go through is the management of nicotine use disorder. And nicotine use disorder, why am I saying not smoking cessation? I'm focusing on nicotine use disorder is because currently we have a new kid in the block, which is the vape. And if I were to just put it at smoking cessation, then I'm putting myself at a disadvantage because vape is currently rampanting and it's currently being used openly, and everybody seems to be fine with using it. So that's why the topic is management of nicotine disorder, as we are dealing with the addiction in nicotine. So in the management of nicotine use disorder, there are two components that need to work hand in hand. We need to focus on the behavior therapy about it and the pharmacotherapy. It's not only pharmacotherapy, because that itself is not going to get you a successful person to overcome his nicotine addiction. So therefore, behavior therapy is crucial. And only after you have achieved the behavior therapy or know roughly that this patient falls in which category, whether it's a pre-contemplator, contemplator, or in preparation or in action stage, only then can you proceed to know what medication is required for him. So it's quite a...
Sorry, could you share your screen, please?
Oh, I'm so sorry. Yeah. Is that all right?
Yes.
Yeah. So yeah, so we are going to focus both on the behavior therapy and the pharmacotherapy. So the behavior therapy is extremely crucial. So we'll just run through this is a CPG of 2018, which covers quite a bit. You can read that up, but it doesn't really give you a flavor of how to start medication for the patient, For instance, not like the CPG for hypertension or diabetes, whereby at HbA1c of 10, what medications, how many medications could you give? With hypertension, at what stage would you actually start the medication, or which medication can be given? With smoking cessation, it's a bit, it was a bit different. So now we have come up with a toolkit, which I'll share in a bit. So you can have a look at the CPG. There's a new CPG that should be coming out by the end of next year, I think, if I'm not mistaken. So the key messages in management of nicotine addiction is willpower has a very low success rate. It is important for the patient to attend the clinic, yes, but not solely dependent that if the patient said, yeah, saya boleh berhenti, saya ada keinginan, yeah, on its own, it's not going to help, because as we know, we are going to be dealing with the withdrawal symptoms, we are going to be dealing about their relapses and any triggers. So willpower alone is not going to get you that success rate that you require. It is important to initiate the treatment, yes. Now, asking about smoking and assess readiness to quit are mandatory for all healthcare providers, be it a MA, a nurse, what you call it, a doctor or pharmacist, a physiotherapist, dentist, everything, all of them need to ask this crucial question whether is their patient that they are seeing on their table or in their room, is the patient a smoker or not a smoker? And now you have to add another step further and ask whether is that patient a vapor, and is that patient looking for help to quit smoking? And if not, maybe you can share a quick insight on what the dangers are. The third thing is the treatment of quit smoking is available and very much effective. And these are a bit about the 5 A's, which it's part of the CPG, which is a brief intervention. You know, the first thing, like I said, you have to ask and then advise the patient on what are the clear and strong personalized urge for them to quit smoking, and assess their willingness to quit. If they are not willing to quit, which is in most cases, or they're not ready, then you got to jump to the 5 R's, which is talking about the relevance, risk, rewards, roadblocks, and repetition. I know that 5R is a bit of a mouthful, but by the end of this lecture, this 2 hours lecture, you should be able, I'll share with you a toolkit and also questions whereby you will be an expert by the end of by the end of the 2 hours to be able to assess this. All right. The fourth point is to assist. So if the patient is willing to quit, then you probably have to do the STAR method, which I'll share further, what needs to be done, and then arrange for a relevant follow-up. Now, before this, smoking cessations in the clinic kesehatan have only been focused to the what you call it, expanded scope or dedicated service of smoking cessation. But now, currently in JKWP, we have tried our best to promote it to outpatient departments. So, with the use of the toolkit, which I'll share shortly, you will be able to commence treatment on the first visit itself if the patient requires it or not, based on the behavior therapy, based on their nicotine intake, and based on how much nicotine are they taking in daily. So this is not anymore restricted to only a specific set of doctors or a specific team is going to be managing it. No, we are not going to alienate it anymore. We need to integrate it into the day-to-day services in primary care, outpatient departments, or anywhere. Even in general practice, you need to start it on the spot rather than referring to the quit smoking clinic. Maybe the first attempt, you can start off the medication and the follow through can be done in a quit smoking service clinic, fine. But you should initiate and hit the iron while it's hot rather than waiting for them to go for a specific day. Say they see you on a Monday and my clinic, say works on, the clinic is only available on a Wednesday. They have to wait 2 days in order to get the medication or to see the doctor. So we want to cut off that time and we want them to start it on the Monday that they saw you rather than waiting, because those 2 days is going to be very crucial. If the patient has come in with intention to quit or he's in preparation stage, you need to give him the medication and relevant advice at that particular visit. All right. So this is something that we've done in the clinic. So brief intervention has been divided into 2 sections. One is brief counseling and brief advice. So it's very cheap and effective tool to increase quitting, whereby brief counseling is only 30 minutes. So you would do that probably in the smoking cessation service. Of course, it's difficult or impossible to do it in the clinic kesehatan. So 30 minutes for a patient is heaven. You probably could see 4 patients within that stipulated time. So what you need to do in the outpatient department is probably a brief advice, which is 5 minutes. If you're having your own general practice, yeah, then by all means do the counseling for the 30 minutes and get the correct cover the correct ground, like withdrawal symptom, what are their triggers, how much are they taking, and all of that, so that you will get the doctor and patient alliance bonded within that brief counseling period. Now, what is brief advice? So, brief advice is something short, sweet. I like to explain to everybody brief advice is like an advertisement, all right? An advertisement is only 30 seconds, sometimes less than that, and they have to pass their message over to the consumer out there that this product is nice and you should buy it and go. So, you got 30 seconds. Here, we're giving you 4 to 5 minutes to spend with the patient. So, it's simple, opportunistic advice to stop and assess the patient's attempt, commitment to quit, and also offer them pharmacotherapy or behavior therapy and provide self-help material. I will indulge further about the details about this in my next slide, okay? And what is quite interesting is there was a study done whereby they found out that the numbers that need to treat to obtain one long-term quitter for a brief advice, which is less than 5 minutes, is every 40 patients you see, one would successfully get treated. And those that are using medications like NRT or varenicline, they need to see 20 in it. So it's not really a bad deal for the number of patients that you see. You with your brief advice is not going to waste, because when we talk to other doctors, they said, "Oh, the patient's not listening to me," or the patient is just putting it in left ear, taking out to the right ear. But it is getting somewhere. Believe me, it definitely works. After being in this addiction team for a long time, I've realized that it really works. And those who have trained also have come back to tell me that, doc, it actually really works. So please do not underestimate or look down upon the brief advice that is there. All right. The other thing is we need to understand that the stage of change. So there's a bit of a history about the stage of change. It was done by Francesca Di Clement. Basically, it's not a stage of change specifically for quit smoking, but it's for everything. So whereby you can go through the stages of change in order for them to move towards recovery. So this is a bit of a full slide where it tells you about the pre-contemplators, the contemplators, preparation, action, and maintenance. What you need to take back from this slide is that this is a cyclic. uh, it can go anti-clockwise or it can go clockwise. If it's going clockwise, you're doing something right. If it's going anti-clockwise, something needs to be addressed. Something is not getting addressed in this patient. So a pre-contemplator, if you give him sufficient or good counseling, he could progress to become a contemplator. If you further do a really good job, he could be in preparation or action. Some patients may come to you at the stage of a contemplator, and you have to do that job to push them down to become preparation rather than pushing them and making them regress backwards. So, what are pre contemplators? So, pre contemplators are a person who's not ready to consider a change, they're unaware of the need to change. So, basically, it's like maybe a partner bringing in the husband or the wife to quit smoking, forcing them to come, or maybe a parent bringing the child to quit, or maybe even a grandchild bringing the grandfather to quit, or a child bringing the parent to quit. So this is something that is being forced upon them. So they fall in the pre-contemplative. Yes, they will attend your clinic, but they might not take heed towards it. But your duty is to introduce the 5 R's, start the counseling process. You may not give them medication; they might not have progressed. That's fine. But the counseling and the first encounter is very crucial for you to create that alliance between you and your patient. Then there are the contemplators. The contemplators are ambivalent what patients who are 50-50 about it. They might say, oh, I might want to quit, but I'm worried about the side effects of quitting. I might get, a lot, which is very common among in our society, in our culture, where they say that, oh, if I quit suddenly, I'm going to have cancer, I'm going to get diabetes, they're more scared of the thing than rather the medication. Than the medication. So you need to correct that perception and make this patient a bit more insightful in that manner. Okay, so they might be 50-50 about it. So this is a bit of a challenging one. The pre-contemplants are basically not interested, but the contemplators are the ones that can switch both ways. So you have to be very careful on how to counsel the patient, find out the relevant issues that they're having. Why are they worried? What are their fears? Go through them, draw them a path on how this process is going to take. It's going to take 12 weeks. You need, how much are you smoking? What are you smoking? And or vaping, how much are you vaping? And what are the side effects of the withdrawal symptoms? What are the effects to the second hand, third hand smoking? You got to share all of that to that patient of yours in that thing, because they might not be interested about their health, because they feel that, okay, fine, I'm smoking, it's going to be my issue. But you have to share with them, it's not only that the smoke that you release from the cigarette or the smoke that comes out from the vape, it's still doing damage to your loved ones around you. So they have to be aware about that. Then when you go on to those in preparation stage, are persons to open to change. So these people may have already had some sort of preparation, maybe a couple of months, and they're probably willing to quit. Those in action stage are, of course, probably already quit. Maybe they just had an MI, or they had some family member who died who was a heavy smoker, so they are probably already ready. So these are the easier patients. The preparation and action are relatively easy. And then comes the bigger task, which is maintenance. How are you going to maintain? Because to maintain them for a period is going to be a bit challenging, because the urge will always come back and keep reminding them about the secret. So you have to be very tactful about that. So we have come up with this table, which is also available in the Quit ASAP toolkit that I will share later. So it basically tells you a pre-contemplator, he has no intention to quit, he has no behavior change, and he has no attempts to quit. If you look at a contemplator, on the other hand, he has 50-50 attention to quit. He has a bit of behavior, might not have behavior change, might not have quit attempt. But his thing that is driving him towards it is not the Barisan National Banchi, but it's actually the intention to quit that you see there. So you got to make sure that you push him forward rather than regress backward. Then you come to the preparation stage where he has intention to quit, he has behavior change. Quit attempt may or may not be there. That's fine. And then in action, of course, everything is good and flowery out there. So there's no issue there. So the concept of an ambivalent patient is somebody, like I said earlier, feels two ways about things, likes to content of element of ambivalence. So resolving in the direction of change is important. It's normal. It's a normal process. Clients usually enter treatment with fluctuating and conflicting motivations in any situation, not only for nicotine addiction. They want to change, but they do not want to change. So working with ambivalent patients is with the heart of the problem. If you are able to push them in the positive or in the forward manner, then you probably have succeeded and your counseling is excellent. All right. So what makes people change? Okay, behavior change is about motivation. Information, I'm not saying is not important, it is very important, but you're dealing with a patient here, you're not dealing with a professor or examiner where you need to tell them. This is our patients who have day-to-day issues. They would want information. I'm not saying the patients are not insightful, they are. Patients now, compared to what they were 10 years ago, they know a lot of things out there. They probably could share a thing or two with you, but you have to motivate them and be a great influencer. That's what our duty is, to motivate them and help the person find the source of motivation, but just not to give them, load them with jargon and information, and we are not able to to convince them to quit, because too much of information which the patient doesn't feel is relevant to them, it's going to be a waste. All right, so motivation is crucial. So what we need to do as healthcare providers is the interactions between the provider and the client. We need to increase their change and decrease the resistance. So this is not like diabetes, where I like saying that patient comes in with HbA1c of 10, you can, rattle away and say, kenapa tak makan, kenapa tak jaga makan, why not taking your insulin? You can't do that with the smokers, okay? Because the smokers or the vapors, they find there's nothing wrong with them. People have been doing it, people have been hundreds of years, okay? They might get cancer, they might get other illnesses, but they would never, their insight is so poor, they never related to that. They would blame everything else rather than the smoking. So you have to create that change, but the manner in which we do it also is important. We can't push it upon them. We have to convince them. The behavior change is very, very crucial. Right? So these are the counseling aids that are also available on the toolkit when you see later. So what we have done is we have divided the pre-contemplators and the contemplators, and the preparation and the action stage. So if somebody is a pre-contemplator or in contemplation stage, you got to ask them the 5 R's. But the 5 R's are a bit difficult to rattle off if you've never done it before. I mean, those who have never run a quit smoking clinic would not know what is the how to create a sentence with relevance, risk, and so we have done this for you in the toolkit. You just have to say, why will quitting benefit you? Ask the patient that question. Is smoking harmful to you? What are the benefits of quitting? Health, money, or stamina? And what are the roadblocks? Meaning, what is preventing them? Ask these questions as they are. Let them answer the questions. Not that we rattle away, which we love doing to talk, but let them talk and let's get back their feedback. So this is what it's going to move. So this is the 5 R's. And of course, repeat the motivation the next time they come. This is for the patients who are in pre-contemplator and contemplating stage, which I think a lot of us see, but we tend to say, he's not ready. Don't just leave it at that. Use this 5R. You will hit something on the head, or the patient might come back after a couple of weeks and say, doc, I think I would like to start this process. I would like to try it out. It's fine. But if you do not ask them this 5R, you are going to lose, and so is the patient going to lose. You're not going to be able to attract this patient. So you need to be very careful on what questions, on what are you talking to your patient. I hear some doctors when the patient is smoking and suddenly he stops, and they actually tell the patient, okay, you know what, you've suddenly stopped, I think you should start smoking back again. That's not acceptable. All right. I know the NRT drugs are not cheap. I know they're expensive out there. I mean, of course, I'm quite lucky because I'm in the government service whereby it's only a ringgit. But for those who are out there, if they can't, please don't do that. Please send them to a clinic kesehatan so we can assist them in relevant treatment and give them medication. But as for what I was talking to Nicorette, the scale of the medication, they're having a lot of promotions at the moment. I know Champix is out of the market, but NRT is working pretty well. They also have the gum, they have the patch, they also have a spray now, which works very well. So please do not push these patients away. Let them try something where I will show you on the toolkit how we're going to do that. So those are the pre-contemplators and the contemplators. They are the tough patients that we have to work towards. The preparation and action stage patients are not to say easy, but we have to make them progress and allow them to maintain their abstinence from nicotine addiction. Now, that becomes another challenge. So what you do is the first thing is you reinforce the benefits of quitting. You must tell them, congratulations, you've done well, and you've diverted away. You have tried to avoid this. That you have to share with them all the benefits of quitting, which I'll share in my next slide. What you could rattle through, even in the toolkit, it's available. Tell them about the options, the NRT and non-NRTs duration of treatment for 12 weeks. High chance of quitting with medication. You must share with them that. Get them to set a quit date and rope their loved ones, family members, and friends only if they want to. So you tell only if they want you to do that. If they don't want, then it's their choice. We can't force it upon them. But if not, get them roped in, because it's of course better to get the support of the family and the friends or even the co-workers who are around them. And then you might have to also anticipate the challenges and triggers, meaning to say, um, they are working in an environment where everybody's a smoker. How are you going to overcome? They are working as a taxi driver or a grab driver where they're waiting for their clients or waiting for their customers. So they're going to be smoking and vaping. You've got to find out how are you going to overcome. So you've got to draw a rough path for them on how to overcome those triggers. Like, after meals, they need to have a cigarette, or they go to the toilet. So these are the things that you need to find out. Okay, how am I going to overcome? So, for example, when you're giving somebody the gum, we will always tell them, listen, you take the gum as soon as you're done with your meal. Do not wait for the urge to come and then only take it. Because as we know, and I'll share in a chart later on, the time it takes for a gum to reach the peak from a cigarette, it's nowhere near. A cigarette reaches within 10 seconds to the brain. The gum, the patch, does not do that job. Maybe the spray is probably a bit better, but it's not as good as a cigarette. So rather than waiting for the urge, you start when you know you're going to have it. So I normally give them a diary and I tell them, please mark now, when do you normally smoke? When you get up in the morning, do you smoke? If you do, as soon as you get up, put the chewing gum in. Or if not, you can adjust the patch. The patch can be put in at midnight, and then it covers the 8 hours, which when you're getting up, you have maximum amount of nicotine in your body. So the urge to have that first cigarette in the morning is not there. All right. So you have to come up with methods of how to overcome their challenges and triggers. And also, so this only can happen if once they have shared everything with you, your counseling is going well, and you have explained and gone through all these categoric explanations clearly. If you have not, then it becomes a bit of an issue. So please share with them, draw them a slight career, I would say a career path or a way in order for them to quit smoking. Because if you don't draw them that 12 weeks period, what are they expected to do? What are they supposed to overcome? They are not going to be successful. So you must help them out, and you must share with them. A lot of the doctors do not want to share the withdrawal symptoms with the fear that if I share with them the withdrawal symptoms, they are not going to quit smoking. They're going to get scared. No, we share with them the withdrawal symptom and tell them how it is going to be overcome with the medication, with the NRT, and with other techniques. If you do not share with them and they themselves find out, they are not going to come back to you because they feel that you have not been honest with them. So you must share with them the withdrawal symptoms and how are you going to overcome it. Okay. The sixth thing is to remove, to get rid of tobacco related products. I had a patient a couple of a year ago who was a vape supplier who came for vaping cessation, I mean nicotine addiction cessation. He wanted to stop. He's already had an MR. He's 25. Now I asked him to get rid of his vapes. Now, funny thing is, as things were a bit difficult, he was a vape supplier, so he had a whole storeroom full of. He said, "Doc, I cannot do this." So so things like that. So but they have, because they now with vape, it's super easy. You can put it in the car, you can put it in your toilet, you can put it in your office, in the house, you can put it anywhere. So you don't have to carry around. You don't need a lighter. It's so much easier. I find that vaping is so much more accessible than cigarettes. That is why the number of vapors have increased, and vaping is not an option for smoking cessation. All right. So get rid of the tobacco-related products or the vape before they when they are in this process of preparation and action stage. Now this is the 5 R's which are written, which are a bit overwhelming. You can look it up in the CPG. It's there to encourage the patient to indicate. So these are the full narrations about it, which we have come up with questions which are much easier and quicker. So the questions are, like, again repeat myself: why will quitting benefit you, for the relevance? Is smoking harmful to you, for the risk? And what are the benefits of quitting in the sense of health, money, and stamina? So you got to find out what are their triggers. Is it because their health that they're having this issue that they're coming to see you? Or is it because of financial constraint? Or is it because their stamina is getting down? Or are they affecting the health of their loved ones? Like their children are recurrently getting ear infection, eye infection, nose infection. ENT issues. So you need to find out, maybe they are causing it, because peds has become very alert, and they start referring a lot of the parents who are smokers and vapors to us for quit smoking, and then ask them what is preventing them from quitting. So for example, if the patient is in an industry like a police officer, he is working in a group of 5 and he wants to quit, the other 4 are smoking away, it's going to be very tough. So try to get them and convince them to do a group counseling, and then see how we can do, or maybe change the team or change the roster. So there's a lot of things that need to be looked into. So it's not so simple as per the counseling, but after practice, you will actually get the hang of it. Right now, this is we used to look at the guy on the left regularly for the past 40, 50 years. Now he's really been there on smoking. Now we have on vape, but of course the data is coming in slowly because it's just introduced in 2014. But I assure you, it's getting more and more information. So it's not safe or safer than smoking, and the harm reduction thing is not really acceptable because we are finding out more and more medical problems. Okay, so when anybody always asks me, "Doc, what's the difference between smoking and vaping?" I always just tell them, listen, if you're a smoker, you're jumping off a 30-story building. If you're a vapor, you're jumping off a 25-story building. So it's the same. So there is no safety net that it's slightly safer. There is this big talk about prescribed nicotine for among general practitioners in the UK and in Australia, which have all gone wrong, and they have cancelled it. So things are not going as per what it is. So it is fine. They're beginning to find that it's dangerous. So please do not prescribe vape or e-cigarettes or IQOS as your alternative to smoking cessation, because that is not the right thing to do. Use the NRTs that we have. Of course, we don't have the Champix, but it's okay. We have NRT gum patch and also the spray, which has just come in. So they are very effective. And I could vouch for it. It is not, we had used Champix for many years. And when COVID hit and we didn't have Champix, now I'm using the NRT. The success rate has not dropped much, maybe about 2-3%. So it's not too bad. It's actually doing pretty well. And a lot of Jabatan Kesihatan Wilayah Persekutuan clinics are doing much better with NRT alone. So I don't see a reason. It's not acceptable for somebody to prescribe vape to a fellow patient for smoking cessation. All right. So needs to be very clear. You can share with them this about the long life addiction with vape, ear and eye, throat irritation with vape, chemical residues, cardiovascular diseases, cancer, heart diseases, harmful chemicals, and all other, even the smoke that's coming out of the vape is considerably dangerous. So you have to be very careful with giving misinformation to patients. I know there are a lot of articles out there, but they are not done with a good group of patients. They're very limited. I'll share with you later, courtesy of Prof. Haniki, of course, who shared a bit of the articles where a lot of studies have been done by the vape companies in order to promote vape as a smoking cessation toolkit. When in actual fact, when you look at the studies, they are very small amounts and they are not effective, and they are not good studies. So you can come out, you can, like how the story about the statins came out, where they took out statins, and the American company took 10 patients of 20 or 30 patients who had symptoms and did a study on that. So it's very biased. Okay, and we must understand that the tobacco company and the vape companies are all hand in hand, and they are trying their best to push their product out there. So you have to be very careful with not with prescribing vape unnecessarily to patients who are trying to stop smoking. All right. Now, regarding the smoke, so those patients now who have are not bothered about their health and they are uh, created like Superman and Iron Man, they feel that if they are going to get the disease, it's their problem. We must share with them this that it is not really an issue. With They are causing more problem to the surrounding environment, meaning to say that they are killing the children around them and the adults around them. How? Like, for example, if you look at the thing about the kana, they'll have ENT problems, they have lung issues. This is just by the smoke of vape or cigarettes, okay? And easily getting lung infections or, sudden death syndromes among babies. And in adults, they'll have recurrent issues with ENT. Those who are asthma will not be well controlled. And they could also have a possibility of getting lung cancer and heart issues, and also they could have issues with fertility. So you must share with them this, because a lot of times we do not share with them the risk of the smoke, the second hand and the third hand smoking. This picture is courtesy of Pfizer, which was available. I don't know those who have seen Pfizer in 2015 and 16. They had a brochure. So this picture I feel should be plastered everywhere in every clinic, GP or KK hospital, because this is what is going to get you half. This was very helpful to us when we were starting off, because we found this picture creates quite a bit of awareness among how children tend to follow in footsteps of their parents, and which is happening now. We have a lot of kids out there who are vaping in schools, and this has become a big issue. And we've been giving a lot of talks. The children know so much about vape in comparison to some of the doctors out there. So we have to be ready for this, because now our problem is not only the adults, but we also have to deal with the children who are vaping and smoking, because that is, they are below 18. They cannot be easily given any NRT product. So we have to purely depend on behavior therapy. We have to purely depend on their what you call it, their support system that is there. And we need to make sure the schools come up with more stringent and more not stringent rules like throwing the kid out of the school because they're vaping, but I think create more counseling. And we have to get the soft approach, because I've noticed a lot of the students that come to me for vaping cessation, the issue that they're having is they're scared to come forward, because they say that if the school finds out, they're going to be thrown out of the school. So this authoritarian or trying to create this capital punishment of throwing them out of the school, which is in their case a capital punishment, because they will lose, and once AADK comes in, it's going to be a mess. So a lot of things need to be looked into the Ministry of Education, in order how we can get the students to come up and tell us forward that they are vaping, so we can help them, because they're scared to come now. The parents are scared to come to the clinic Berhenti Morocco, because they are worried that if their name is registered in the clinic Berhenti Morocco and the word gets back to the school, they'll be thrown out. So this is a current challenge that we are having now, which I think all of you all are probably experiencing, because I get quite a bit of referrals from the general practitioners, the clinic assistants, from the students who are vaping. So yeah, we are treating them. Of course, we are roping in the adolescent specialists and other addiction specialists in order to assess and to overcome this problem now. All right. So for those who are quitters, okay, those who have successfully quit, well and good. So we need to, but we still have to reinforce the decision to quit. Review with the patient reasons and benefits. You have to keep asking them, why are they quitting? What was their reason for quitting? Not they are quitting because the doctor asked them to quit, or not because they're trying to get, trying to keep their wife happy, or trying. They need to know. They need to have insight about the dangers of it. So only then will they be able to progress and last and maintain this abstinence from nicotine addiction. And then and keep telling them the benefits of quitting, and keep giving them a pat on the back that you have done well, because they need a lot of encouragement. It's very tough to overcome this urge of nicotine addiction. It's actually far stronger than those who are taking drugs. The amount of time it takes for drugs like methamphetamines or marijuana or ganja to get to the brain, it's slower than cigarettes. Cigarettes and vape are far faster, is within less than 10 seconds. And the thing about nicotine addiction in comparison to drug addiction, vape and smoking is taken when you're happy, when you're sad, when you have an issue, when you don't have an issue, when you're celebrating, when you're down. So it is not mood dependent, as in only when they're down they're going to take it, or when they have urge to take it, they're going to take it anyway. After a meal, they're going to take it because they're used to that habit. Going to the toilet, they're going to take it. So it's quite challenging to overcome nicotine addiction among patients, and it's there. You can see everybody now vaping, and the number of female vapers have increased tremendously because of the factor of it being a bit more easily accessible and looks cool rather than the cigarette. And the thing with the vape is you do not need to light a cigarette or find a corner or hide somewhere and do it. You can just take in a slow puff and then put it back and then release the smoke as you go along. So it's become very, so the frequency of usage is much higher than that of cigarette. So that is a bit of an issue there that I think we all are facing, right? Now, this is the STAR method, of course, where we set a quit date and then we tell about the family members, like what I said earlier. Okay, these benefits of quitting is what you must share with the patients within 20 minutes. What happens? The pulse rate returns. Why is this happening? Because of the neurotransmitters, your dopamine and serotonin and everything that is there that is being released. So you share with them. This is also available in the toolkit when I share in a bit. All right. And then you also have to share them the non-pharmaco aids, such as self-help materials, advice from the healthcare professionals, individual and group counseling. That depends very much on your patient. Hypnosis, there's no real articles on it, but it's one of the things that were mentioned. But study-wise, not much has been done about it, so I can't really comment much on that. Acupuncture, Rehab Cheras was supposed to start something. I'm not sure how that is going, but yeah, but there are a lot of things out there. All right. And just to reinforce the key message for this is willpower alone has a low success rate, and asking is mandatory for all healthcare providers. So you have to ask, please, when you're asking for blood pressure, pulse rate, and all, please ask for smoking and now, of course, vaping. And the treatment is available, effective, and helps to reduce the withdrawal symptoms. Now, a bit, these slides are from uh, uh, Miss Pharmacist Sharon and Prof. Aniki. So just to share with them, you've got to share with them the withdrawal symptoms. I know there's a lot to remember here, but in the toolkit, it's quite easily available. I'll show you how to use it there. So you have to tell them about the increased appetite for 10 weeks, urge to smoke for more than 10 weeks, irritability and aggression for less than 4 weeks, depressive mood for less than 4 weeks, restlessness for less than 4 weeks. So all of this, difficulty concentrating, sleep disturbances. So this is happening because the nicotine is being withdrawn from the brain. All right. So you need to share with them and tell them the treatment is about 12 weeks. So this will overcome that. Okay. So basically, going back to the nuts and bolts of things, the mechanism of action. So nicotine binds to the nicotine acetylenic receptors in the central nervous system, and that's when it kind of like recreates the dopaminic pathway and releases more nucleus accumbens, and basically that is what releases your dopamine and your other neurotransmitters. So rather than releasing what normally would be released when you're having sex or when you're having a sporting activity, or would be actually far more exaggerated. So we have to share with them that how it actually works. So when we collapse this thing without anything, cold turkey, without medication, that's when the withdrawals are terrible. So this is when you need to give medication, the NRT especially, or if you had Champix, which is not available, to reset and to have sufficient amount of dopamine to be reset to what it naturally is available in the body, right? So which one to use now? Which medication is safe, efficacious, suitable, and the cost? We'll just go through this. So NRT and varenicline, okay, fine. Varenicline, no doubt, it is it was the best. It is the best, but we don't have it at the moment in the market. NRT, as you can see, is pretty down there, but it still works pretty well, better than the placebo. So it's doing something right there. Okay. The first lines are, as I mentioned earlier, and you need to be very. We don't have nortriptyline and bupiron available in our settings in primary care. So we only have NRT to deal with, all right? These are the NRT guidelines, which I'll share in the toolkit, so it makes it a bit easier. So this is the graph that I wanted to share with you all about how the cigarette intake is far higher intake. This is less than 10 minutes, all right? So if you see, to reach such a high concentration of nicotine is only the cigarettes, okay? If you talk about your inhalers, if you talk about your lozenges, if you talk about your patch, if you talk about your gum, it doesn't come close to this, all right? Even the snuff, the moist snuff that is there, it's coming after 30 minutes. So it's quite fast. That is why you can't wait for the urge to come for them to give the gum after they milk. Let them take it straight away. The patch maybe needs to be readjusted to the timing because it takes about 8 hours to overcome. So you need to adjust. This is very important. This is for you to know that it is tough to quit smoking and what are we actually dealing with. So they're not going to quit in the first visit or the second visit. It may take 2 to 3 weeks, but it's okay. because we are not here to have a race with them to see who quits faster, because the process is quite daunting and challenging. And a smoker, when he's going to quit, he's going to go through a lot of challenges and a lot of issues there, right? So what are the NRT that we have? We have patch and gum, all right? So lozenges, of course, we don't have. So what is the gum? So the gum comes in two strengths, 2 milligrams and 4 milligrams. All right, and you can't exceed more than 60 milligrams in a day. So the gum, the issue is a lot of them think of it as a chewing gum. Even some of the pharmacists and doctors, sometimes when they prescribe, we tend to take it for granted. The patient might know, but the patient doesn't know. So you must share with them that this is a gum, yes, but it's not a chewing gum. So how they chew is very important. Things to consider when you're giving the gum is chew it in the right way, not like a regular chewing gum. Acidic drink foods and amount available for absorption. Use enough of it, about 10 to 15 pieces a day, 4 milligrams for heavy dependence and 2 milligrams for low dependence adolescents. The adolescent part is very tricky because you need to get the adolescent specialist to see, and you need, when all uh, other avenues have been exhausted, only then can you use the gum. Okay, recommended of use is about 3 months. So how do you take the gum? A lot of them take the gum wrongly. When they come to the doctor, I've tried the gum is useless. When you ask them how they take it, they say, I take it like how I'm taking a chewing gum. So it's wrong. The technique is crucial, like how we teach them for inhaler technique, insulin use technique. Similarly, the gum has a technique, and if you do not follow, you're not going to get the most out of it. So tell them to chew it 10 to 15 times, park it between the buccal and the molar, leave it there, and whatever saliva that comes out needs to be spit out. Because when they don't spit it out, they swallow it in, they have sore throat, they have stomach upset, and then some of them they chew the gum like a chewing gum and they end up having jaw. The texture of the nicotine gum compared to a Wrigley's gum, the shell is extremely hard. If you keep chewing that, you're definitely going to have jaw ache and other issues. So 10 to 15 times chew, keep it between the buccal and the gum and the cheek, and then you can keep changing when the taste disappears, and you can discard it after 30 minutes and take the next one. So this is what it is. So it's very important. This is all available in the toolkit. So um, you can actually go through the toolkit after this. Okay. Now things to consider, I think chewing technique, using of dentures is going to be a bit tricky because it's going to get stuck there. And then frequent consumption of acidic drinks, food is going to be an issue. Habitual smokers after meal, so you need to tell them when to use it and what gum strengths to use. And new flavors of the gums are more palatable. I mean, they are there, but now it's only one flavor. We only have the mint. We don't have anything else, right? But it's so readily available, so you can actually get it and give it to the patient and let them start it. But let's make sure they're taking it correctly. Now, the things about headache, hiccups are all due to swallowing of the saliva. GI discomfort, joy is because they're using it like a chewing gum. Sore mouth and sore throat because of the swallowing. So the saliva needs to be spat out. So this becomes a disadvantage to people working in offices when they have to keep spitting it out. So they are not too happy with this. This is when maybe the spray can help. The new thing that is out there, maybe that's a good option to try. Okay, now we come to the patch. So the patch that we have is a 16 hours patch, which is into three doses, 25, 15, and 10. So in order to use the patch, you have to make sure of a few things, that the patient is not too hairy. Okay, put a new patch in the morning or at night, doesn't matter. Upper arm, side of the torso is hairless. Do not put on the same place for 3 days, especially if there's redness. So basically, a lot of them develop contact dermatitis with the patch. So make sure they put the patch on a different place every time rather than the same place. So you start off with the 25 milligram, depending on what is the dosage of the patch that you are actually going to give them. All right. Now, things to consider again are hairy. If somebody's too hairy is going to be a problem. But now, seeing that with the new patches, they are very good. Even you can have a shower with them, and they're not going to wear out. So they're actually pretty good. The older ones used to slip off. This are actually pretty good. Okay, and even if they're working out, it's not too bad. They have the only problem is it's not suitable for those who have the hand and mouth habit. So that's when the gum comes into play. Okay, you can start according to the toolkit, and I'll share with you in a bit. And it's also for 3 months. So the patch is put on, and then it's taken off. Okay, now when to use the patch? Now this graph is extremely important. If you look at this graph, if I were to put the patch at 8 in the morning, I'm only going to get maximum effect after 8 hours. So if this patient is the patient that gets a big urge in the morning, and he puts it at 8 o'clock, he's not going to get anything till 4 o'clock. I mean, he might get at 12 o'clock, maybe about this amount, but it's still very low. So what we recommend for these patients is to put the patch at night. So if they're putting it at midnight, they would get maximum within 8 hours when they By 8 o'clock in the morning, they should have this peak should have been here. So therefore, they are able to overcome that craving at that time. Okay, so this is very important to adjust the patch according to the patient's craving. If it's not his issue is more at 11 o'clock, change it accordingly. You can do that. So there's no hard and fast rule that you have to give it in the morning or you have to give it at this time. No. So you do it accordingly. Everybody is different, all right? So this is very important to note that the nicotine plasma concentration time profile of the nicotine patch needs to be known in order to when to give and when to apply, all right? Side effects that they have are headache, dizziness, nausea, palpitations, and insomnia. So this is in the CPG. As you can see in the CPG, it's clearly mentioned here the chewing technique, okay, for the gum. And patch also, they have mentioned quite a bit of things. So the smokers with time to the first cigarette, I'll share with you what this is later. So the first cigarette tells you how high dependent the patients are on the, I mean, how much, these are the patients who are considered high dependence nicotine addict that need maybe a stronger dose of patch. So, but this has already been resolved with the toolkit, so it makes it a bit easier. The precautions that you need to take is pregnancy, lactating women, and you have to be careful with the patch and the gum. The gum in pregnancy, you need to weigh the risk versus benefit. If they really are smoking 20 cigarettes or vaping a lot, then maybe you can give the gum. But if they're only doing one or two cigarettes, you have to be a bit careful with that. Second thing to consider is cardiovascular diseases should be used with caution among those who immediately within 2 weeks of post-MI period, serious arrhythmia or worsening angina not to be given. All right. So there are special populations that you have to be careful with. One is a pregnant mother, the lactating woman, cardiovascular disease, also with those who have psychiatric disorders, but now they're saying there's no issue with that, and the adolescent group. So you got to weigh the risk versus benefit with them, all right? And as I mentioned, the side effects are what I mentioned earlier, right? So the non-nicotine replacement therapy, sadly, varenicline was very good. I know we don't have it in the market, but just to quickly share, what it used to do is this is the nicotine that was binded to the nicotine receptor. Champix or varenicline will actually is a partial agonist, so it would bind to the nicotinic receptors and reset this whole pathway of your VTA, and therefore reset. So therefore, you're actually not having any nicotine in the body, but you're getting the reward. It's not completely crushing off. NRT is something like methadone, where we're giving a replacement. Champix is no nicotine, but you're resetting the pathway, and it actually was very effective if you look at the charts I showed earlier. So the superiority of Champix is, of course, without a doubt there, but we don't have it at the moment. So there's a 12-week program. The first week is at 0.5. The second week is at 1 milligram. And that continues on for the next 11 weeks, right? 14 weeks. So these are the continuation packs that are there. So if you look at the meta-analysis that was done, varenicline is superior to a single form of NRT compared to combination. So varenicline is, of course, very good, but now we don't have it. Till we get it, we have to use the NRT. All right. And this is another one saying about the most efficacious smoking cessation agent. All right. So it is varenicline. NRT is not too bad. It's there. So I don't think you should feel. We have used it. We have been after COVID. I didn't have any varenicline in my clinic, and I was solely depending on NRT, and it's not done a great disaster to my success rate. So I think it is. It's actually very good. Just use it the correct method. Compliance technique and how you're going to use it is very important, which is the nut and bolts of even using an inhaler for that matter, or even your insulin. So we have to educate the patients more. Okay. So this is a bit of trials about that. So the side effects of this used to be nausea, abdominal pain, flatulence, headache, dream disorders, insomnia, and also behavior and mood changes. Okay. So since we don't have it, I'm not going to too much into this. So there was a study done evaluating adverse events in global smoking cessation studies. So overall treatment was tolerated for varenicline, but this was done for e-cigarettes. Now this is what I want to share. So the evidence is inadequate to interfere that e-cigarettes in general increases smoking cessation. Right? Evidence is suggestive but not sufficient to infer that the use of e-cigarettes containing nicotine is associated with increased smoking cessation compared to the use of e-cigarettes not containing nicotine. So evidence is suggestive but not sufficient. You have to understand that. Okay, it's just suggestive. Okay, then more frequent use of e-cigarettes associated with increased smoking cessation compared to less use of e-cigarettes. This was done by a US Surgeon General report in 2020. A Cochrane study also was done where it says, can electronic cigarettes help people stop smoking and do they have unwanted effects for the process? So of course they will stop smoking because they will switch from this to e-cigarettes. All right. And there was another study done on vaping in England and evidence of updates, including vaping for smoking cessation. Now, the issue with these studies is nobody reads the whole study and they just infer from that or that it's safe by looking at that. So there is moderate or certain evidence that e-cigarettes with nicotine increases quit rates. Of course, they increase quit rates because you're switching from one product to another. Compared to e-cigarettes without nicotine and compared to NRT, evidence comparing nicotine e-cigarettes with usually care, no treatment also suggests benefits, but it's less certain. But as they say that more studies are needed to confirm this degree of effect, particularly when using modern e-cigarette products. So the confidence intervals were wide for data on adverse events or side effects on other safety markers. Overall, incidence of side effects was low across all the study arms. No clear evidence of harm from nicotine e-cigarettes, but longest follow-up was 2 years. So it's very small data and it's very small numbers that were used in order to do this. So effects on vaping of smoking. Using vaping products is most popular aid used by people from 2020. As we can see, the numbers also even in Malaysia have increased. All right, vaping is positively associated with quitting. In 2017, over 50,000 smokers stopped smoking with vaping products. Of course, because they are switching from one nicotine product to another. Prescription medication and licensed NRT from harm reductions were also positively associated. Extensive use of vaping product in quit attempts compared with licensed medication suggests vaping products may reach more people who smoke and so may have more impact than varenicline and NRT. But the study profile is very small, like I mentioned earlier, so you have to be very careful about prescribing it unnecessarily to the patient, right? So I'm just going to move to my next slide now. Okay, so the next slide is actually going to share about a bit of depth before I go into the toolkit. So is to understand this. So it might be a repetition from what we did before, but it's basically to emphasize on the important points of the previous slide, right? So we know that it is an addictive drug. These are the tobacco products. And then what is in the cigarette, the 7,000 chemicals, we know about it. The e-cigarettes come in many different, they have the mod box, the sub-ohm tank, the cartridges, and the e-liquid. And the vaping liquid, which contains the chemicals. So basically the difference between vape and cigarettes is that cigarettes is using the leaves, vape is using the e-liquid that is there, and that is inhaled into it. So the mechanism I'm not going to ponder about. What I need to share here is that it's currently being used widely among children. And that is worrying because a lot of the children look at this popcorn looking things or this bear looking cute little bear here. So what is this trying to prove? So they are trying to get new market, which is the children and the adolescents. You have to be a bit careful with about that. So what is the content in an e-cigarette? Same as what it is in a cigarette, but we are still learning as we're going along. There's things, elements of paint in it, fireworks in it, paint thinner, coins, nail polish removers such as acetone and embarking fluid. University Malaya has come up with this Hebat uh, campaign where they actually share you this picture where they're talking about the heavy metals, nicotine is still there, the artificial colors, and the food preservatives. So the thing that vape gets away with is when they mention food preservative and they tell people, oh, it's safer, it's got FDA approval. It has got FDA approval, yes, but FDA approval is for food, and we're not dealing with food. We're dealing with lungs here, so we're not dealing with the stomach or the gastrointestinal tract. We're dealing with the respiratory tract, so we need to be very sure and educate the patients that this is going into the wrong track. All right. So that part needs to be clearly spelled out to them so they are aware about what to expect, not just dive in blindly and with the studies we saw earlier where they just come up with a study with a small group and done over a short period and suddenly they find, voila, it's safer to use that. So it's not, okay? So this is what we need to educate our patients. And then, of course, we have to educate the children at the same time. So like I'm just going back again to this, the understanding of nicotine dependence. So nicotine dependence, the mechanism action, like I mentioned earlier, is also to the nicotine receptor. So these are the neurotransmitters that are released. So we, as healthcare providers, have to understand this clearly that what the patient is experiencing, especially for those who have never smoked or vaped before. So in nicotine, there are many neurotransmitters. There is dopamine, norepinephrine, acetylcholine, glutamate, serotonin, D, endorphin, GABA. So it releases pleasure and appetite suppression, which patients is a selling product. Appetite suppression, everybody wants to lose weight. So when they smoke or somebody tells them that you can lose it by smoking, they would take it as an opportunity. But we must share with them, yes, you do lose weight, but at what cost do you lose weight? You end up picking up other diseases such as cancer and other more sinister diseases that are out there. So you have to share with them this. So take every one of these neurotransmitter and tell them the effects that they're going to have. Then they might have arousal or appetite suppression. Again, arousal, but that needs to increase the content. So they end up taking more nicotine than what they were doing before. Cognitive enhancement. Who does not want cognitive enhancement? But tell them this cognitive enhancement is temporary. It's only going to serve at a certain period of time, and then you will probably need more and more. And by the time your receptors and your cells are going to get damaged, learning improvement and memory enhancement also need to be addressed, and tell them that this is a short-term period. It's not going to be there forever, and it's going to cause further damage. And later on, you're going to have more issues trying to learn or have the memory enhancement. Serotonin, which is mood modulation. Again, you have to share with them that how they could actually have issues with that in the long term. Reduction in anxiety and tension. These are probably one of the reasons why patients who are very nervous or patients who are, stressed out tend to take it, because the B endorphins and the GABA is very prevalent in nicotine, which helps them with this feeling. So we have to understand the short-term rewards so that we can educate the patient. This is what you're experiencing now when you're smoking or vaping, but it's not going to last forever. And one is that, and the second thing is we are going to give you something to overcome this, because this in the long term is going to damage your receptors, it's going to put you will make you an addict, and cause other kind of medical problems, cancers, and all of that. So you got to educate your patient on this, all right? But of course, don't have too much, but just share with them. This is more for those patients who are well read, and they want information. You can share this with them. Okay. Now, the incorporating of the 5 A's into the clinical practice, I already mentioned this about the 5 A's. So it's just a run through for completeness sake to identify these are for also patients who are exposed to secondhand smokers. So ask them about tobacco use and about their exposure to secondhand smoke. So a lot of them may not be using nicotine, but they may be exposed to it. Identify the document that uses status. So you ask them that, then you advise them smokers to quit, non-smokers to avoid secondhand smoke. Okay, and then you refer directly to the general practitioners, or they have a lot of quit lines, MQuit, or even to the clinic kesehatan, or you can assess them, assist them, and arrange them. Now with the toolkit, you should be able to move onto the right-hand path whereby you assess, assist, and arrange. So you will be able to treat the patients right away. This is again the brief advice. So what is it in the brief advice that, like I mentioned earlier, you're going to cover? So you're going to talk to them about the advice to quit smoking. You're going to tell them about the cancers, about the cardiovascular risk, about the respiratory problems, the reproductive issues, and others. So you have to share with them what is the benefits, or what are they, why should they quit. So this is what we normally need to do. Talk about all the different cancers that are there, cardiovascular risk, and everything. Share with them this and give them some insight on what they are. The lung cancer, the number one cause is smoking. Ischemic heart disease is also due to smoking. COPD is, of course, long-term smoking. So you got to share with them all these issues, okay? And then on the brighter side, share with them the benefits of quitting. Within 20 minutes, the heart rate starts coming back to normal. The CO levels reduce. Now, the CO analyzing machine that we use in the smoking cessation clinics are not applicable for vape patients because they do not have carbon monoxide. So don't get thrown back when suddenly you find a patient coming in vaping and his CO is zero. It's normal, okay? So that's why the CO is only limited for smoking cessation and not for vaping. Then you can share with them the 2 to 3 weeks later the risk of developing a heart attack, or the lung function will improve, and then their coughing and shortness of breath will decrease. Their risks of other chronic heart diseases will actually get better. Risk of lung cancer reduces. All of that needs to be addressed, and share with them these things, because in your counseling you need to tell them about the benefits, because this is to keep them knowing that why are they doing it, because they're not having any symptoms at the moment, majority of them, so they find it's normal. So you got to share with them this, that it's going to be beneficial. The famous thing that they like to ask is, my grandfather has been smoking for 90 or 80 years, he lived until the age of 100. Yes, of course he did. The life expectancy is dependent on what God has given us, but how we like he must have been regularly going for a nebulizer or going to the emergency department, probably as a frequent visitor of the asthma or COPD bay in the emergency department. So you got to find out the quality of life and share with them that yes, he lived until this, but he was a liability on the family rather than an asset. He could have been so much more productive even though he was old, but because he had so many debilitating diseases due to his smoking that he was not able. So you got to find out what exactly, and you got to, not that we're trying to rub salt on the wound, but we need to educate them, but do it in a nice way, okay? And even the way, in order to share with them, try not to come across as being hard or harsh, because these patients are not going to come back if you are too rough or too hard with them. They're just going to walk out of the door and say, fine, it's okay. I'll just take my luck and see what's going on. Then those patients who are not scared by this cancer or cardiovascular or respiratory, you would want to focus on the second hand and third hand smoking with them, whereby their smoke from their vape is going to cause them issue. All right. So now, what we have done is, in the toolkit, we have taken Fagerstrom score stage of change at daily nicotine intake daily nicotine content, and calculated how much is required and what medication can be produced. All right. So this is what the scoring system. I think everybody is aware with Fagerstrom score, but for e-cigarettes, they also have a pen state electronic cigarette dependency. But in our toolkit, we are using the modified Fagerstrom score, which is for a vape anyway. So the Fagerstrom score basically tells you what? The Fagerstrom score tells you the time to the first cigarette. Like I mentioned earlier, about they get up in the morning and they need to have their cigarette within 30 minutes of waking. If it's less than 30 minutes of waking, then they're high dependency. If it's more, then it's slightly low dependency. This is when the patch I was telling you earlier needs to be put in earlier, so that if they are in the category of high dependency, the patch probably should be put at night. If they're in the low dependency, you could actually put it in the morning then, right? So this is, but you don't have to crack your head on when to prove what, because the toolkit has already summarized all of this and it will make it very easy for you. So coming back to the assessment of stage of change, which is, of course, not many of us are aware about it, but we need to identify the patient to which category. So if the patient is, you can use this graph as a guide. All right, daily nicotine intake, we are looking at something like 1 to 2 milligrams per stick cigarettes. And for vape, we are looking at 15 puffs would be equal to 1 milligram. So the toolkit has already done that. There is a calculator which I'll share with you on how we're going to use it now. And the withdrawal symptoms is also available in the toolkit. So while you're counseling your patient, you can just pop up your toolkit on the side of your desktop and share with them the withdrawal, the benefits. They're all available there, as I will share with you shortly. Right? So that is a quick recap of what we did earlier. Now I'm just going to dive into the toolkit, a bit of the history of the toolkit before I start showing it to you. So this is called Quit ASAP 2.0. As you can see, it's my Clinic Kesihatan Tanglin's Nicotine Addiction Management Toolkit. Why is it not Smoking Cessation Toolkit? Because we are going to deal with any nicotine product, be it vape, IQOS, or anything that is. So we are focusing on Nicotine Addiction Management Toolkit. All right. So, what is the Quit ASAP 2.0? It's a web-based toolkit developed to aid healthcare providers to three main aspects of smoking cessation: the counseling part, like I mentioned earlier, assessment, and treatment. This toolkit should be able to initiate the first line, which is very important, because once you know the first line, then the second and third you can actually depend on you can adjust it according to the patient, and also you can taper down. If nothing, just taper down, hold it by the 8 weeks, 2 weeks, and 2 weeks. Now, this toolkit should make everybody an expert in managing nicotine addiction, because it's basically a method to get the treatment and how to which treatment to give and how much to give, how long to give for. Everything is mentioned in it. Okay, so this is why we came up with this toolkit. All right. Background a bit about this toolkit. Why was this toolkit developed? The majority of quit smoking services in health clinics, like I mentioned, are dedicated team of certain doctors, pharmacists, and paramedics, where else not all doctors, pharmacists, and paramedics were in the were in the quit smoking clinic, so they are unable to start medication. In the outpatient department, the issue was not all medical officers were able to counsel, assess, and initiate optimum treatment. So therefore, they would refer the patient. Like I said, the clinic is on Wednesday, Monday patient comes, it gets wasted. Similarly, with the pharmacists also are trained for smoking cessation. So they are unable, those who are not trained are unable to start medications, or, so they're missing the golden opportunity. In the quit smoking services clinic itself, in the dedicated clinic that we have, there's a long duration for counseling. We take about 45 to 60 minutes, but now with the toolkit, it's become much faster. And due to, in service, that the staff turnover is very high, So we need something that when somebody comes for training, it's done fast. So the next doctor that comes is able to take over. As we can see, there's a lot of changes in the staff turnover in the clinics. And the rationale behind this is the prevalence of smokers in KL is 19.8. This is the old national health office. I'm talking about the new one that was recently announced by Dr. Zul, but that's a very good one. It tells you a lot about the vape and about the latest data, which shows that vape has gone skyrocketing high. Okay. And the target for the end game was to reduce to 5% prevalence, meaning that everybody in JKWP or Kuala Lumpur need to have 9,000 quitters a year. In the government side itself, we are only achieving 200 because we only have dedicated quit smoking clinics. This toolkit is supposed to, or is going to probably help to let anybody and everybody manage or initiate the smoking cessation treatment for the patients that come to see. So how did we develop this toolkit? We took the Fagerstrom score, we took the daily nicotine intake and the stage of change, and we combined it and created 64 possible combinations. From this 64 possible combinations, there are 11 treatment options that are available. And this is the evolution. Came up with the algorithm, and then we came up with flip cards, and then with an Excel sheet, and now it's web-based. So what is before and after? So the MOs in OPD did not initiate treatment for the eligible clients, whereas now eligible clients are being given the medication. Pharmacies did not dispense quit smoking in OPD. Now they do, other than the non-quit smoking dedicated clinic days. We used to get 2 to 3 clients recruited each month. Now we're getting 8 to 9 each month. 3 to 4 monthly attachment from doctors to our clinic for training. Now they only need a 1 month attachment because the toolkit is quite self-explanatory and easy to use. And the quit rate for in our district, Pejabat Kesihatan Lambang Pantai, is maintained. So there's no drop in the quit rate. This is my team. Dr. Nur Faiza is my FMS, myself. Mr. Sugendran is our pharmacist. Dr. Praveen is unit primer. He's the one who created the Excel sheet to initiate the first quit ASAP toolkit to 1.0. And Dr. Ehsan was the creator of the web-based design that we are having now 2.0. And my MA, and our backbone of the Quit ASAP toolkit, Mr. Nur Shavika. So this it was a TWG project was done by Jabatan, and we actually went on to get further engagement with the experts like Prof. Muhammad Haniki and Dr. Helmi Haja Maidin. I think everybody knows Prof. Haniki is an authority in smoking cessation, and Dr. Helmi Haja Maidin is also quite heavily involved with smoking cessation and vaping. You can see a lot of his Instagram postings on that. And family medicine specialist, my FMS Dr. Nur Faiza had presented to the FMSs in July Persekutuan, and we had got their endorsements for this toolkit. So we went ahead and started training for it in 2022 in my own clinic, Petaling Bahagia, 2022, same time, and Clinic Mohiba. And then we presented it to the Jabatan, and then 20 clinic Kesehatans have all been using it. And since then, we've been having quite a bit of visits from other PKDs over Malaysia who've been coming. And we actually won the innovation. This was the innovation toolkit. We won the first place, both district and also in national level in 2022. Whereby that time was the Excel sheet. So now I'm going to share with you. We also did a poster presentation in the International Medicine in Addiction Conference in Melbourne, which was we found out that they actually at that time we even brought out about the vape, because this is when the vape prescription vape prescribed vape by the general practitioners was brought up, which later on in July it was undone, and now they are not what you call it doing it anymore, and they're trying to curb the use of vape. So now, without further ado, I would like to jump into the toolkit. So if you guys can open your phones and type quitasap.net, okay, you can use your phone or you can use your desktop. The reason we use the phone is because in the clinic sometimes it's a bit difficult. Not all clinics have a desktop, so we use this. But this, for the purpose of now, I will show the desktop. So this is how it is. So this is the Quit ASAP Toolkit live. So as you can see, this is the home page, and it has choose. So it basically tells you, well done for recruiting a client for smoking cessation. Choose smoking products that the client uses, cigarette and heated tobacco if they are using this, or if they're using vape, you click on either or. If client uses both, you can choose more frequent one and use both, or you can use the calculator. So we'll go into this in a minute. For counseling methods, click the bottom. So if the patient does not want to, you want to just purely focus on your counseling, and you know which stage the patient is at, you can click directly here. These are additional references, which are the quick references, which I will share with you all in a bit. So say, for example, I have a patient who is smoking cigarettes, for instance. So I'll click on this. As you can see, I just clicked here, and it brings me up to this page. So Fagerstrom score, not everybody knows what Fagerstrom score is. We don't expect anybody to know what it is because it's a lot of things to remember. I don't think we need to add this to our memory list. Just go to the calculate button, and then here you can key. Say the patient says I smoke within the first 5 minutes. I can abstain from not smoking in other places. I have a first one in the morning cigarette, and I'm smoking about 21 to 30 cigarettes a day. And then smoke more during the first few hours of the day. Yes, and I can eat. I can control myself not to smoke when I'm ill. All right. Then you press calculate, and it tells you the moderate dependence, and you put proceed. So the number has come out here. Then you go on to the nicotine intake. So the patient says, I smoke cigarettes, 20 cigarettes a day. It gives you the nicotine intake, and you can go on here. Stage of change, you might not know. It's okay. You go to assess. The chart that I mentioned earlier in the 2 slides is here. So you identify your patient as which category. So if you find that the patient is in preparation and ready to quit, process the next 1 month, then you just click on this and you go to proceed, and then all your uh, 3 boxes are filled, you proceed to treatment. Then it tells you treatment plan H, reinforce the benefits of quitting, what is the counseling section, what is the medication, and what is the follow up. So you can use this straight away and tell the patient that you're going to use the reinforced benefits, the STAR method, what medication could you give, and when is your next follow up for this patient. So this is for an example of that. So for instance, if I am already been using it so often, so I know that the Fagerstrom score is 10, and this say is 50, you can just change it. You don't have to go back to the calculate and say, I see the patient's a contemplate. I just process and I'll get the treatment. So you don't really need to go here to calculate if you're already considered like an expert, like you really know what to do. All right. So this is one there. This is for cigarette smoking. If somebody is a vapor, using vape or e-cigarettes, you click on the vape section. Okay, say their Fagerstrom was the same. This is based on vape. So the same method, you just fill in the questions that you find out from them about when their vaping history is a bit, the Fagerstrom score, and you proceed to calculate, and there you get an amount. And regarding the vape, okay, for vape, you need to understand that nobody's going to remember how many puffs are they doing in a day, right? They're never going to tell you that, doc, I think I did 200 puffs today. No way. What you do is you go back to the device that they're using. So if you look out there in the market, there are a lot of devices, Volt Bar, NanoStick, iKios, all kinds of stuff. You have to identify the device that they bought or the cartridge that they bought. How many puffs did it have? So if they are using a NanoStick and say it has 6,000 puffs, how long did they take to finish? Say they said, doc, this NanoStick 6,000 puffs took me 6 days to finish. You divide that by the number of days, and you would have got the patient using 1,000 puffs a day. You will get the nicotine content, and then your stage, of course, if you know in action, and you proceed, and you will get the treatment for this patient based on their daily nicotine intake. So these 3 things come into play for if their patients. So you just calculate based on the number. So if they're using what you call it, Volt Bar, 15,000 sticks, and they are finishing it within 10 days. So you're looking at 150, 1,500. So they're using 15,000 puffs is available in their Volt Bar, and they finish it within 10 days. So they're using 1,500 puffs a day, and you just calculate and you proceed. So it can be done very easily. If the patient is using both vape and cigarettes, so you know he's using 20 sticks a day, and you know now he's using the 1,500 puffs a day. You just add it here. You add the 30 milligrams to the 130, and you will get the. So you can just change it directly. You don't have to go back to calculate again. So this is a matter of just getting used to this. It's actually very simple, and it gives you a treatment on the spot for which medication to start when. So you don't have the headache of, maybe I've undertreated or overtreated. This will clearly tell you. So for example, if you look back at this patient, This patient should have been given high dose nicotine 4 milligrams when necessary, plus nicotine high dose for 25, the patch 25 milligrams. Right. So you start this medication, and maybe you can follow up in 1 week. If it's nicotine gum, maybe 2 weeks. Okay, depending on your flexibility, but you know what to start with the patient. So you won't undertreat. So, for example, if this patient is a pre-contemplator, okay, we're not going to give any medication to him. We are going to focus on the counseling, which is the 5R, and we are going to go into further detail in the relevance risk. So go back and ask them about this 5. They need more counseling. So it depends very much on the type of patient. That's why you have to select the patient correctly. And this toolkit helps you to tell you which needs medication, which doesn't need medication, which needs treatment, which you can need more counseling. So those kind of things. So if the patient needs more counseling, you can just go to the counseling aid directly and just not go this part. Go straight to the counseling aid. And the patient falls in the category of pre-contemplator and contemplator. You go through the 5R questions again. If they are in preparation and action, then you focus on these questions again. So this is the toolkit. So it's quite simple and straightforward. The click of a finger, you will be able to start your medication. Now, in counseling, you might need some kind of data, as in a lot of schematics. So I just run through what is in the quick reference. The reference first one is the 11 key messages. So the 11 key messages, I feel everybody should go through. This is from the CPG. So the first things first is ask and document smoking status of all patients. Like I mentioned today, we have to ask. If you don't ask, patient comes to you for cough and cold, patient comes to you for any other issues, and you do not ask whether it's vaping or smoking, you're not going to know. He's not going to tell you, all right? Because he thinks it's perfectly normal. And with a lot of newspaper articles out there saying that vaping is safer, better than smoking, they're going to say, it's okay, doc. It's Cosmo said this yesterday or Cosmo said that. So those kind of things, you have to ask them and tell them, no, it's not correct because it's going to cause you other problems. Okay, so you have to ask and document the status. This should be part of your triage. Provide brief advice. Like I mentioned, the brief advice is very important to the patient. You can either use individual, group, telephone counseling approaches in combination for smoking cessation intervention. Okay, assess level of nicotine addiction using the modified Fagerstrom test score, which we are doing now, and verify smoking status using carbon monoxide. But this is because the 2018 CPT does not mention about weight. All right. Offer pharmacotherapy to all smokers who are attempting to quit unless contraindicated. All right. If selected, use NRT for at least 8 to 12 weeks. So you have to use NRT for at least 8 to 12 weeks, or even varenicline for 8 to 12 weeks. Second is combination works really well. If you keep a patient patch alone and you feel the second visit that the patient said, doctor, I've got a lot of cravings in between my meals, you can add in the gum without a hesitation. You can add it in. So don't be too. Combination actually works pretty well. All right. Then the use of smoking cessation medication, you have to be careful with the special population. All right. This toolkit does not take the patient's profile, whether the patient is pregnant or breastfeeding or he's adolescent. We don't have that because we don't want to take the data of the patient. So if you have the special population, please assess whether that particular patient is whether it's a child, adolescent, pregnant, breastfeeding, woman, psychiatric, or substance abuse disorder. Please look at that before keying it in and not just key it and then say, okay, we give the medication, because these are the special populations that we need to exclude before using the toolkit. Arrange a minimum of 6 to 8 face-to-face visits. Okay, you can't just give the medication and say, okay, I'll see you back after a month. That's not going to work. Okay, you need to probably Zoom call them, Google Meet with them, or WhatsApp call, whichever that works best for you, or even get to see them face to face to assess them, to tell them that how are they doing. Because the first week, I what I normally do in my clinic is the first 4 weeks I see them every week regularly, are the first 4 consecutive weeks, because I make sure that they might have side effects. Maybe they're taking the gum wrongly. Maybe they're developing contact dermatitis with the patch. Maybe they are having some roadblocks from their triggers, factors are not addressed, or they're having some other issues. So you need to see them for the first 4 to get them going, and to so the 4 visits are very important. And then please apply. I don't know how much more to emphasize. 5R is incorporated in the motivation interview. It's very important. Motivation interviewing is a completely different, very big topic by itself, especially of course. But we have to somehow or other get it out these 5 hours and put it to our patients, because that makes a big difference, right? You can easily switch a patient from a pre-contemplator to contemplator, or even from a contemplator to preparation, if your counseling and your grasp and your control of your 5R or your motivation interviewing is strong. So it's very valuable, right? So provide the other thing you got to provide is relapse prevention. It's very important to have relapse preventions and tell them that it's I mean, don't tell them in the beginning it's okay, but when they come back, you say it's fine. We can actually go through this again. We can assess you again. We can readdress your problems again. Look back at the history. There's something we may have missed out during our counseling, or some trigger that the patient may have not shared with us, or maybe he's stressed. So the doctor-patient alliance in this nicotine addiction is extremely paramount. If you do not develop that alliance, you're not going to be able to get the patient to quit, because if the patient does not buy you your word or does not trust your counseling or your methods, you're not going to. So you got to really convince the patient. It's pretty tough. I'm not saying it's easy, because you're dealing with an addiction here. It's very tough. So you need to come up and you need to share with them information, get information from them, and then come to a deduction, because it's very challenging. It's not just giving a medication and saying, okay, you take the gum and go back and eat, and then tomorrow we see you. Nope, it doesn't work like that, unfortunately. You have to work on the behavior, and then you have to get the pharmacotherapy. Well, the behavior therapy is extremely important. Behavior on its own is not going to work also, in saying that you got to work hand in hand for it both to work very fluid, and only then the patient can move towards abstinence from cigarettes. All right. So this is the first one about what you call it, the 12, 11 key messages. Then we have the 5A strategies, which I've probably mentioned earlier already. Then you got the STAR method that is also there in the CPG. That's also here. So please read at your free time. This is the narration of what relevance means. Encourage the patient to indicate why quitting is personally relevant. That's why we came up with the questions, because it's much easier to use the question than to use this, because you are there sitting in front of your patient. You're going to have a great difficulty trying to create a question. Here, the question is available for you, and you just have to click on that question, and you will get questions straight away rather than going through this. So we've made it a bit much easier that way, so you don't have to waste much time there. All right. Then share with them the benefits of quitting. Okay, this is very easy. Share with them that in 20 minutes your pulse rate will return to normal, oxygen level in 8 hours will return, in 24 hours your blood pressure. So explain to them. They'll ask you, how, doctor, why is this happening? You said because nicotine increases your heart rate, which eventually increases the makes your heart work faster, make your heart work more, it causes you to cause blood pressure, causes you to cause heart failure, and then other components that are there, your blood becomes thicker, the hematocrit increases, therefore the oxygen requirement of the body increases, and then you tend to have more thicker blood. So all of that you can share with them for those patients who are insightful and who know and who want to have information, sure. But the information has to be given tailored according to the type of patient you're seeing. If the patient is from a lower social economic group and you tell them about things, and they're just going to be looking at you and staring at you. So everything has to be tailored based on the patient. It's not one that fits all, right? So that is very important to know. Share with them the hours that you have, the days, how many weeks, how many months later, and how will they improve. This is all available. So put it through and tell them that there is light at the end of the tunnel. Like a lot of my patients that say they say sekali dah rokok tiada maaf bagimu. There's no such thing. There is maaf bagimu, and so you have to share with them that there is hope at the end of it. Okay, so you have to share with them that. Share with them the withdrawal symptoms. This is quite easy to go through. If the patient is extremely he's read very extensively, or what, you probably can share something a bit more detailed, like this withdrawal symptoms, which goes through the diagnostic criteria where it tells you that the chest tightness, the constipation, very much more detail, but it's there for you to share with the client who probably has been well read and well educated. Okay, these are important things to say. So it's all available on this toolkit, so you don't have to refer anywhere else to get it. Okay, and then for the pharmacists, they probably want to do the Wisconsin withdrawal scale. Okay, that also can be used. And then coming to the medication. So all you got to do is tell them how to use the medication. So you can share with them the dosages of, say, varenicline for the first 3 days, how to do within the 4 to 7 days, what to use, and then the treatment options. Administering, how are you going to take it? What are the duration? What are the side effects? So this is all for you and for them. So you can You have all the information that needs to be mentioned here. For the gum, you can actually go through this and tell them that how to take the gum, okay? Because we might not be too familiar with it, especially if you're running a GP practice. Maybe you might not be having a pharmacy on board, so you can probably use this to tell them the correct method. Or when they come and see, they say, "Doc, I've tried the gum, but it didn't work." So go back and revise this and say that did you chew it correctly? How were you taking it? How many times did you chew? Did you swallow the saliva or did you spit the saliva out? When did you, were you drinking any coffee or tea when you were taking your gum? Did you take out the gum and then put it back again that it gets oxidized? So all of that needs to be addressed. So you have to share with them these things, because if you don't, it's not going to be helpful. All right. So you've got to go through, like I emphasize again, compliance of the use of this medication, the duration up to 12 weeks, the side effects, share with them that these side effects are actually not side effects, but it's because you've taken the medication wrongly. You have used it wrongly. You have swallowed your saliva. You have been chewing it non-stop. These are all problems that are causing you to develop this side effect. So if you do it correctly, you won't get this. And of course, coming back to it again, the precaution is crucial. You must tell them about the pregnancy and lactating mother. Okay, you must make sure that you are not prescribing the medicine unnecessary, saying that there are mothers who are actually coming to see me from the clinic kesehatan, or the clinic kesehatan ibu dan anak, and whereby they are smokers. You'll be surprised at the number of patients that are actually smoking who are pregnant. We would probably think otherwise, but it's actually quite a big number. And these patients, when they come, the first thing I need to identify is how many cigarettes are they smoking. If they are smoking a packet a day, I'm not going to stop them and say to them, a packet a day, and say, listen, you can continue. No, I'm going to tell them, I think you should try the gum and take it for 2 milligrams, and then see me back next week, and then we will assess again. If they're smoking 2 cigarettes, I'm not going to give them the gum, of course, because the gum is going to be it's going to cause more harm than benefit. So you got to assess that part. All right, please do that. With the adolescent patient, I've been seeing quite a bit of adolescent patients, and a lot of them have successfully quit vaping purely on counseling and frequent reviews and a good support system. Okay, in a support system, I mean the family, and I also mean support system with our staff. So this is very important. And I actually had never given any adolescent nicotine gum, because they didn't require it. They just needed to be motivated, and they needed counseling, and then I had a counselor on board. It was very helpful. So you can actually do quite a bit there. All right. The other precaution group that you have to be careful is the cardiovascular disease. So use with caution for those with MI, 1 to 2 weeks. Please be very careful with that, because that is something that we don't want to cause harm to. All right. Now the other thing is the patch. So the patch, on the other hand, is very effective. But like I said, you got to use the graph I shared with you earlier on how to take it, when to start it, and the three doses we have is 10, 15, and 25. So basically, if I have a patient who has 25 milligrams started, I would give the patient 25 milligrams for 8 weeks. But of course, I'm going to see him in between, and then I'll reduce it to 15 milligrams and then 2 milligrams. So it depends very much. You have to cut down and then go off to the gum. Okay. So apply new patch on hairless areas. Start applying in the morning after waking up, or even at night. So there's no hard and fast rule on that. Remove at least up to 16 hours. Rotate and avoid using same side. The patch is actually very effective if you use it correctly, even the gum for that matter. So you have to use it correctly. All right, duration is again 12 weeks. Side effects could be skin reactions or insomnia. Precautions, again, the same precautions. So I think there's nothing to worry about that, but please be careful about the precautions group. Okay, so this covers the nicotine toolkit. So this Quit SAP toolkit is very, very much available. If any of you all have any questions that need to be answered, you can actually always contact me. Once you use the toolkit, you land yourself into any kind of problems. That's my number and my email address, and I'll be glad to help you all to see how it's going. If there's anything that causes any hiccups there, right? So I think I'm nearly done with my talk. Yeah. Is there any?
Thank you so much, Dr. Takdir, for such an informative session on the crucial topic of smoking and vaping cessation. Your insights and expertise definitely have provided us, as well as other healthcare professionals, with valuable knowledge and strategies. So now we will move on to the question and answer session. We've received several questions through the Docketing app, and we will dive into these questions. The first question is from Dr. Ru. He asked how to quantify amount of nicotine being absorbed into our body via vaping, especially during deciding the NRT methods for patient and during the time when deciding the dosage of nicotine gum and patch to use.
Yeah, so I think this was covered in the when I was explaining about the toolkit, whereby you have to identify what device are they using first of all. So if they are using, when the patient comes to you, you got to ask them what device are they using. Are they using? There are so many devices in the market now. So normally I tell them, can you bring the vape device so I can have a look, or you just look up the website, because these vape companies have become so advanced.
Mhm.
They have developed websites. Like if you look at this website, if I just can share with you the screen, if you don't mind, just to share. Let me see if I can open it here. So one of the examples would be Volt Bar. So it actually tells you. 1 second. So
Doctor, you can share the screen.
yeah. So the vape companies are far ahead of us. I must tell you that. We are actually lagging behind. So if you look at this website, can you see the website?
Yes.
Okay, so I'm older. Okay, so fine. You see, they ask the question, am I older than 18 or less than 18? Look at the color that they have put here. Is above 18 going to use this color? No, they are definitely not going to use this color. It's below 18 that's going to use this color. So this is a trap to get the younger users. But coming back to the question of Doctor earlier, so it's 12 puffs or 6,000 puffs. So go back and find out what device is the person using, all right? And based on that device, you are, say, for example, even you put Volt Bar here, so you type in the brand that the person is using, okay? Nano Stick. There are a lot of brands of Nano Stick, so you just can go to the Nano Stick and whichever brand that they are using, it will straight away tell you, ask them, adakah anda guna bahan ni, and which brand are using, how many sticks are there. Again, you know, they are, so you can roughly know from there how many units are they using, how many puffs is there in all. So they will explain to you which puff and how many puffs in the cartridges. So based on that, you are able to identify what device. If it's 15,000 and they are using that 15,000 device for 10 days, take 1,500, okay, 1,500 and put it into the calculator like I shared earlier. Share it again. So I go back to the nicotine, the toolkit. Okay, I go back to the Quit ASAP toolkit. So if the patient is using um, this Volt Bar that is 12,000 puffs within 10 days. So 12,000 divided by 10 is 1,200, and there it gives you the nicotine. This is your nicotine content that you're asking for. So
Okay.
based on this, you can put it into the toolkit and you will get the amount. And then it will tell you, say, for example, the doctor doesn't know how much patch to use. So you proceed here and then you check the Fagerstrom score and say the patient is in preparation stage, proceed. Amount of nicotine is there, 4 milligrams and 25 milligrams, all right? So you can use this, and this answers the question, I think, about the how much nicotine, what device do you use to identify this, all right? Is that clear for the question?
Yes. Yes, doctor. Thank you so much. Moving on to the second question. For patient who is using vape without nicotine content, we still can enroll them in our KBM clinic by teaching them behavioral methods such as 12M, 5R, and STAR.
Okay, first of all, I would like to share there is no vape without nicotine. Okay, they may tell you that this guy said that, even if you look at the Volbar website, they say there's 50 milligrams of nicotine content in the 15,000 puff, which we have checked a few times, and it is actually underquoted. Why they do that, and why they say there's no nicotine in it? Because they want the buyer out there to buy. Now you tell me, how can you use something? There must be something that is causing them to be an addict to that particular vape. Maybe nicotine, may not be nicotine, maybe other drugs, maybe mushroom, maybe other kind of amphetamines or something that is using to cause them. And when they come and tell you that the strawberry flavor or the mango flavor is making me want to do vape. That is utter. There's no facts behind it because there's no way you're going to have a flavor. There is content, there is nicotine. There may be other substances that are being used like katom, cannabis, marijuana. Could be a lot of other things that are being used. Yes, you still enroll them. Like I had a patient who was on mushroom in a vape, and it was an adult. Then later on, we found out, these energy sticks that they came up with, that Dr. Zol has recently banned. So a lot of patients came with that. I still enroll them because I will do my research on that particular product, and I will be able to find out there is definitely nicotine content in them. Use the number of puffs, put it into the calculator, and treat them as you're treating a person with vape in the nicotine. But I tell you honestly, all the vape products have nicotine in them. All right. So yes, you can enroll them in your KBM clinic and treat them as how you would treat these patients, the same. The behavior methods such as 12, yes, use all of it. Please do. The 5R is more, okay, let me just re-clarify. The 12M is basically the 12 methods how to abstain from smoking. They're very useful. They were very effective when we had COVID, when we had the quarantine centers. I didn't have medication to give them. We used the 12M session. The 5R is very important to convert those pre-contemplators and contemplators to move to preparation and action stage. So that is very crucial. The STAR method are for those patients who have already planned to quit. If you look at my table, you can see the patient falls in which category. So yes, please use the method. Guys, please do not. I had doctors who said they were running a smoking cessation clinic, so we do not deal with vape. No, we deal with nicotine addiction. That is why I've been emphasizing, and I think they might change the name very soon. That we are going to change the name to Clinic Berhenti Nicotine, Clinic Ketagihan Nicotine, because we are smoking cessation is getting to become obsolete at the moment. It's not obsolete, but it's not as popular as vape and other e-cigarette products. Okay.
Thank you, Doctor. Moving on to the third question. Can patient use vaping as a bridge to stop tobacco smoking?
No, not at all. There is no evidence. There are a lot of studies that were done and have failed. The number of studies, like I mentioned earlier, are very small. When I presented that poster, which you saw earlier in Australia in February 2023, sorry, now it's 2024, 2023, during that conference, there was a public health specialist who brought it up saying that we are going to give prescribed nicotine to patients. And from there, that was in February. In July, when we rebutted it in that February conference by talking about EVALI and these kind of things, they were not very happy about it. But in July, they have banned it. So it's not a bridge to stop smoking. Please do not do that. It's not an alternative because you are putting them on something new, which we ourselves do not know the dangers of and which we are finding out now. EVALI was not there when I was in medical school. I think was not there when Thareenee, you were in medical school too. EVALI is something very new. We are just learning about it. So please do not start something which has not been validated, is not been approved. It's not, we have NRT. Use the NRT. Do not use the vape. I know the vape is cheaper, but what it's going to cost the patient, we would be responsible for it. So do not use that as a smoking cessation or a nicotine addiction toolkit. All right.
Okay. So moving on to the next one. Is it true that vape has lesser nicotine content than tobacco smoke? And is it true that nicotine has only addictive properties but no other harmful effect on body? Therefore, NRT is offered to patients.
Okay, so nicotine vape does not have lesser content because I can tell you this from my experience in treating vapors for the past few years. The amount of NRT that I need to use to treat a patient who is a vapor is far higher than a patient who is a smoker. In the context that we treat, like I said, NRT is used to substitute the product or the tobacco or the nicotine product. So I am actually using higher content of nicotine in comparison to a smoker. So it's becoming more difficult for a vapor to quit because there is definitely a higher content. It's not a lower content. It might say in their websites, in their thing that it's less, but in actual fact, when we see the patients on the ground, when I treat my patients in my clinics and in other clinics, we have noticed that it's more difficult to quit a patient from vaping than from smoking, and more resources of the drug is used. All right, so that's for the first question. And is it true that nicotine has only addictive properties but no other harmful effects? No, it does not, my dear. Nicotine has a whole list of problems. The reason why we offer NRT is we are offering NRT like how they offer methadone to the drug users. Okay? Methadone needs to be controlled, NRT needs to be controlled and given in a tapered fashion. All right? There is a lot of articles which say that you don't get addicted to it, and so far I've not seen in my clinic patients getting addicted to it. They don't get addicted. What they do get is they have given up their cigarettes or vape, and now they're on the gum. They do not want to release the gum because they feel that they have nothing else to go to. So that becomes an issue. Whereas in my clinic, what we do is switch them from the gum when they are very well to vitamin C chewables, which kind of keeps their oral fixation sorted out. So it's not only the addictive properties, but its other properties. Nicotine increases your heart rate. Nicotine increases inhibits your what receptors in your body. A lot of receptors in your body, increases urination, increases diarrhea, gastro. So it's not only addictive properties. Addictive properties is the main reason why we are taking it. Yes, but the other product or the other side effects that come with it are quite a few. So they are harmful. But for some reason, the engineered NRT does not give you those. You see, like how you take the pure content of nicotine. Now, nicotine has many subtypes, in the one that they give in the cigarettes or in the vape. So in NRT, it's engineered to give you just that sufficient, clean, pure amount. So it reduces the other harmful products, because I don't see anybody on NRT who has developed increase in heart rate. Whereas their heart rate actually, what I use in my clinic is I monitor the heart rate from the patient first day of visit till the day he quits. We can see he's coming with a heart rate of 80 or 90. As he quits, his heart rate begins to come down to 60 and his blood pressure becomes better. Of course, his weight goes up, increase, which is a positive sign. So it is not only addictive properties, but it's other issues that come with it. All right.
And then moving on to the next question, doctor. Some patients claim vape has lesser chemical than tobacco smoking. How to counsel them to stop vaping by giving some facts?
Okay. So what you need to do is, like I said earlier, I need to share my screen again. You need to share them this slide. Maybe it's actually available in the University Malaya website, where you can share with them the effects of vaping and smoking. So this particular slide is very very important. Okay, where's my slide? So you can share with them this slide. Okay. Now in this slide, it clearly tells you that this on the right is for vape. So all the chemicals that you get, like lifelong addiction, why is it lesser? Okay, cigarettes have 7,000 chemicals. Vape has not reached 7,000 chemicals. Cigarette was founded hundreds of years ago. Vape is just started in 2014. We're only 10 years into the game and we have already started picking up problems. So you need to give them information. Go onto, there are a lot of websites out there, legitimate websites by CDC, by WHO, by the universities, which share with you the effects of vape, and you can actually get a lot. This is one of them that you should actually share with them. So it is not, it is less because the fact that it is newly founded, it's not been there. So we are still learning as we're going. Like Ivali is a clear example of vape. We have a whole new disease now. We never had the disease before, so you have to share with them that part. All right.
Okay, thank you, doctor. Question number 6. How to decide which patient needs NRT, which patient need non-NRT methods?
Okay, so you can use the toolkit to know that also, but I'll share with you this. In order to decide NRT, is the if the patient is contraindicated. For instance, I mean, we don't have any non-NRTs at the moment, but if we did have in a hypothetical, we had the non-NRT and the NRT, I would give non-NRT to those patients who are at action stage and at preparation stage to to use it because they may have reduced their number of nicotine use. So I wouldn't want to start them back on the rigmarole of patch and gum and then to get them through. Whereas NRT works very well as to block the receptors and to get them to forget or get the receptors to not have the taste of nicotine anymore. Whereas those patients who are very high dependent, 40 cigarettes a day, or they are using 1,500 puffs a day, they are using 100 milligrams of nicotine a day, those patients may need NRT in order for us to switch them from one this nicotine product to NRT and then taper down. Why? Because Champix will work. I'm not saying it's not going to work. It has worked. I've tried it. It's a brilliant drug. But the issue is the drop from using 100 milligrams to suddenly zero. That 1 week is going to be very torturous for them. So I would normally taper them down with NRT and then maybe somewhere middle put in the non-NRT. So you got to that needs to be played very carefully. But saying that, some of them may be high users, but they are at action stage and they are really keen to help. You can try non-NRT too. But I hope we do get the non-NRT back because we don't have it at the moment.
Thank you, doctor. And then question number 7. Can patient apply both 10 milligram patch and 15 milligram patch at one time if there is no stock for 25 milligram patch in the clinic?
Yes, you can. Yes, you can. Actually, to be very honest, we in the Ministry of Health are restricted of the use of NRT because we don't have enough stock. But you don't cut it. Okay, if you have some people try they have a 25 milligram but they don't have 10 and 15, then they cut. The moment you cut, the medication is gone. You want to use 2 patches, it's fine. There's no issue. Even when I was in Australia, the addiction specialists there will use 3 or 4 patches together. So because they have funding for it, they have money for it. We haven't got that much funding, and it's not cheap to buy the patch and gum outside. So, but I think Nicorette has shared quite a bit of. They'll give discounts, and so I think you should try it out if you can to sell this to your patients. But yeah, you can use 10 and 15 to cover 25, no problem with that. But don't cut the patch. Don't cut the patch.
Okay. And the last question for today, doctor. Are Champix and NRT only can be given to adults more than 18 years old who have any contradiction?
Okay. Okay, so you can give more than 18 years old. Yeah, you can give no problem for NRT, NRT and Champix. You just got to be careful of the contraindication. 18 is a very early age, but yeah, according to the guidelines, according to the literature, no problem. You can use NRT and Champix for 18 and above. There is no issue with it.
Okay, and another question that just came in. May I know
Sure.
why is the nicotine content via vape is calculated using number of puffs? Because different nicotine solution has different concentration. Some has
Yeah.
0.3% nicotine concentration and some has 1.6% nicotine concentration, etc.
Okay. So the reason we are using the puffs is because we are not certain with the concentration. If, for instance, you know exactly how many milligrams are there, you can key in directly. You don't have to wait for the puffs. But because the products out there are not standardized and they have not been validated, we don't really know how many puffs are giving you. So we have taken based on a study saying that 15 milligrams is 15 puffs is 1 milligram. Based on this study here, I just share with you. So but if you know the content, by all means, please do it because that will be even better for all of us. Then I just share with you this study where it shows us about the this one here. So here it basically tells us that the study was done in 2015, where it says 15 puffs is equal to 1 milligram. But if you can know the percentage, put the percentage directly in. Nobody's going to fault you for it because the issue now we're having is the products keep changing. Okay, so we do not want to undertreat these patients. If you slightly overtreat, it's okay, but if you undertreat, the patient will not get the effects of the nicotine from the NRT and they will continue taking their gum and patch. But like what the question 9 has mentioned, if she has the content and she knows the content that the patient is taking, key in directly. You can key in the milligram. You don't even need a calculator. Like say, for example, if you want to key in this back to the toolkit, you just go directly to the toolkit. And if you know the content, you can just change the milligrams here. Say you're thinking that the patient is taking 40 milligrams a day, you can just proceed with the plan. There is no need to go to the calculator for the patch or the gum. I mean, for the vape or the cigarette. All right. So that is totally up to you. But the problem is a lot of us, a lot of the people out there do not know how much to put in. And we are actually currently in the midst of trying to, maybe by next year I would be able to tell you, but we are in the midst of trying to identify every product. We want to make this toolkit based on the product. So if you're using Volba, you click Volba, and how long you're using for will tell you. If you're using nanostick, so like what or the question 9 doctor is asking is, if the patient is at 0.3, it'll be a particular brand, 1.6 a particular brand, but because we are trying to send to the labs to get back those feedback. So hopefully by the time next year, this toolkit will be able to have that. I think there's another question.
Right.
Is that okay?
Yes, that's amazing, Doctor. So thank you for all your insightful answers to the questions and active participation from the audience from the Docketti app as well. So this concludes our session for today. I would like to extend my heartfelt thanks to our esteemed speaker, Dr. Takdir, for an incredible, informative session on the crucial topic of smoking and vaping cessation. Thank you once again for joining us, and we look forward to seeing you at our next session. Have a great day, everyone. Thank you.
Thank
Thank
you.
you, Doctor.